So thank you all very much. This is our, as you know, this is our Monday evening upper extremity virtual grand rounds, and it is my honor to introduce one of the sort of, I guess, I don't know if a better word, but godfathers in elbow surgery, somebody who is played a big role and influence in the field that we currently have. Many of the techniques and the implants that we use have been brainchilds by Dr. King, and he also had a huge influence on one of our favorite faculty, Nina Sue, as her mentor, and we are all really honored to have you join us. Thank you very much. I don't think you need much introduction, Dr. King. We also have to keep mindful as Canada might win its first Stanley Cup in what, 30 something years, right?
Yeah, it's a 50-50 toss-up at the bookies right now, I gather, between Tampa. It should be a good game, regardless of whether you're a hockey fan. You know.
Absolutely. So we got to make sure we get to that. So without further ado, Dr. King, thank you very much for joining us.
Sure. Well, thanks, Eric. It's really an honor to join you at Emory, albeit remotely. Eric asked me to talk a little bit about total elbow arthroplasties, and he asked me specifically to kind of rehash what I talked about at the ASCS. So I'm going to present that first, and then I'm going to give you some kind of what I would say is tips and tricks for what I think makes it easier to do elbow arthroplasty, or some thoughts about it. So there's kind of two talks. One is kind of more something that I've shown before, and the other is something that is a bit more new. So I'm going to share my screen. So are you able to see this?
Sorry. Yes, perfect.
Is that full screen now there?
Yep, full screen.
Perfect. Okay, great. So this was presented at our joint specialty day in San Francisco. Not that that was overly attended. It wasn't pretty. It was actually pretty good, Eric, compared to the rest of the AAOS meeting, which was not well attended. But that specialty day was, you had a great program on, and you should be congratulated for that, by the way, because it was actually pretty well attended compared to the rest of the meeting. So I have disclosures. I'm going to talk about an implant that I designed. I used to get royalties for it, but not really very much anymore because most of it's patent expired. So I'm less conflicted from that perspective. So when we think about, early elbow arthroplasty designs, we go way back. Most of the implants were actually unlinked, and most of them, some of them didn't even have stems early on. And it turns out these really didn't function all that well because of problems with loosening of the implants very quickly. So then people put stems on the unlinked implants, and they did quite a bit better. I mean, I think the big ones here would be not in this picture, would probably be the Suter Strathclyde and the Gaypar in Europe were very popular, as was the Ewald in America. And then there's a kind of a separate group of implants which were linked and constrained. And the earliest versions of these were actually very, very constrained, and they had very high early failure rates. And soon it was realized that even the Coonrad was converted to a Coonrad Mori, so the hinges were changed, so it was a sloppy hinge rather than a fixed hinge implant. So there's a long history of implants. If you look all these up, you can see that a lot of surgeons trying to design things, and most of them ended up in the garbage bin. I'm hopeful my implant won't end up in the garbage bin, but I'm also cognizant of the fact that most implants eventually end up there. So I'm hoping we've moved the bar a little bit. When we think about unlinked total elbow arthroplasty, it's really a subgroup of patients you're going to think about using these implants. So they need to have good bone stock and ligaments. So these aren't patients that have had some distal humeral fracture that's fallen apart. These are patients with primary osteoarthritis or rheumatoid arthritis. If you're going to put an unlinked implant in, similar to a knee, you've got to make sure the implants go in a good position in order to avoid instability, because even if the ligaments are intact, they need to be placed correctly. Theoretically, an unlinked implant should have a lower loosening rate for a high demand elbow than a linked implant, but it's actually never been proven, and most of the series would suggest there's not much difference, or actually some some series favor a linked implant. So really the problem with these devices is when they work well, they can work really well. But when they don't work, you get this instability problem, which can be quite a challenge. I've shown some implants here. You'll read about these if you read about total elbow arthroplasty. The Kudos from Japan, it's still used there, but it's otherwise been taken off the market in most countries, I understand. The Sorby was a Canadian implant, which was very anatomic. It was great as a Hemi, but it had some design flaws. You can see that, for example, the radial head was not well designed, and it actually had poly articulating with poly, where the radial head would actually touch the polyethylene of the ulnar component and have high failure rates. The Ewald is from Boston, Fred Ewald, and that implant had some very good performance data. The radial head that went with it did not perform well, but this implant was very unconstrained and tended to be unstable. And finally, the one on the bottom there, the Suitor, this was designed in Suitor Strathclyde in Scotland, and it actually had fairly good performance data, but it was actually a very constrained implant. You can see how deep the groove is there, and these actually had a fairly high loosening rate relative, for example, to the Ewald, but they had less instability because of the intrinsic nature of its design. But these unlinked implants can work. This is one of the earlier latitudes I put in one of my patients. She's now 75. She was 55 when I put her implant in, and here she is at 20-year follow-up. This is actually the implant design, which is a change now, but this is what we put in her, and it continues to function well. And we reported on these in 2019, showing pretty good results if you didn't get instability. The problem with unlinked implants is without a radial head, there's a tendency for the implants to drift into valgus over time. And this is true no matter what design you're talking about, whether it was the Cooter, the Pseudo, the Suitor or the Kudo, or in this case, this is a Sorby without a radial head. You can see that by 15 years, the elbow's drifted into valgus, the medial-collateral ligament is stretched out, and this implant is now worn out and had to be revised. Well, why is that? Well, you need a radial head, it turns out, if you're going to probably have an unlinked arthroplasty perform well. The radial head improves load transfer, offloads the medial collateral ligament, and hopefully should reduce wear if you can get these radial head implants to work well. And this is some data again showing the results of the Suitor implant the Sorby implant with a radial head arthroplasty, showing the improved stability after putting in a radial head component in this device. If you look, however, at the track record of radial heads and total elbow arthroplasties, they're all pretty bad. And here's some examples of cases that I've seen over my practice. You can see here a Pritchard Walker, a Sorby, again, showing the types of failures that we see in these kinds of arthroplasties. And finally, on the right, this is the earlier version of the Latitude, not the Latitude EV. And you can see the disassociation of the head from the stem, even though we thought we'd actually developed a much better design. And here's our data showing if the radial head's going to fail with this device, it fails early. Usually it fails within the first year or two, but some weren't really actually truly failed till later on. But most of these implants, when the radial head popped off, were actually still stable and functioning well, but certainly it's a very big cause of concern to the extent that this implant was pulled off the market because we were unsatisfied with its performance. Well, how are you going to make a better radial head arthroplasty, and why are they coming off, it turns out? Well, it turns out there's a couple of issues. First of all, the way this implant was connected, the radial head popped on over with a polyethylene press fit, and the pull-off force was only 97 newtons. We didn't really think the radial head would be actually pulled off in clinical practice, but it turns out some studies we've done in our lab later on shows that actually if you just put the arm in varus, this is a cadaver arm, there's actually distraction forces that occur across the radial capitellar joint, and if there's any ligamentous laxity, the annular ligament holds the radial head and the stem pops out of the implant. So that's something we kind of learned as we went on this journey over 20 years of developing total elbow arthroplasties. So we tried to fix that now. We've increased the pull-off force from 97 newtons to over 2,000 newtons. And this implant now has a peak ring inside to hold it on. So it's kind of like a linked implant from the perspective of the head to the stem. And we've also improved the stem fixation by adding surface treatment. So this is the new Latitude EV radial head arthroplasty. But again, we don't actually know if it's going to be better if we just move the problem down the line. So again, the radial head arthroplasty and total elbow arthroplasty remains, I think, controversial. And the other problem with an unlinked arthroplasty, and the reason most people don't do them, is when you get an unstable unlinked arthroplasty, such as this unstable Sorby, this is a really big problem because these implants were not convertible. And it turns out in order to correct the problem, you have to put in a link device. And in this case, those stems had to be cut out of the cement mantle through corticotomy. So it's a very hard revision. So you can see why there's been a huge swing away from doing unlinked arthroplasties in most countries because of this difficulty with conversion. So one of the goals of the Latitude and also the Acclaim elbow before this, and I think Bob Hotchkiss's new elbow will also have a convertible option, is you want to make sure if you're going to use an unlinked implant, there's an easy path out. So most unlinked arthroplasties that are likely going to be available in the future will have the option to link it to become a stable construct. So here's an example of one of my own patients. This patient had failed an ulnohumeral arthroplasty or an outerbridge Kashiwagi procedure. She was 70. She has no real good joint space, so maybe that wasn't the best choice for her anyway. So I thought, well, I'm pretty smart. I'll do a total elbow arthroplasty. She's still quite active and was going to be more active than most of our patients that we would put a total elbow in. But here she is 6 months later, and you can see the epicondyles have actually torn off in this case, and the elbow ended up unstable. And when we took her to the OR, you can see that both the MCL as well as the LCL are insufficient. So this elbow is unstable, and it's an unlinked arthroplasty. So in the past, this would have been a big disaster, but now this can easily be fixed by putting on a linkage mechanism. So this takes about 20 minutes. It's actually the best revision total elbow arthroplasty I do from this perspective of efficiency. And again, we do this as an outpatient. You basically take the screw out of the ulnar component, pop the cap on, and sew it up, and it's basically fixed. So that solved her problem. But the point is, you don't want to have to operate twice in someone doing a total elbow arthroplasty. And so that's why most surgeons choose to use a linked arthroplasty. The instability is prevented by the linkage mechanism. You have much more expanded indications. You can use it in fractures, bone loss, tumor cases, as well as revisions. But again, we all know that the problem with a linked arthroplasty is wear of the bearing and loosening of the implant from bone. The initial D implant was a linked arthroplasty, but these failed catastrophically, usually within 18 months, because it was such a constrained linked arthroplasty. So all the arthroplasties that are linked that are currently available have some type of looseness in the hinge or so-called semi-constrained. The Coonrad-Mori, the Discovery, the Nexel, GSB, and of course the Latitude also has a loose hinge. So if you're going to use a linked arthroplasty, these are the types of implants you're going to use. And for most surgeons doing a low volume of elbow arthroplasty, that's probably what I would recommend. The problem with these implants is that polyethylene wear is a failure mode. It causes osteolysis, and then you get secondary cantilever bending failure of the stems. One of the issues with the total elbow arthroplasty has been the problem with the bearings. And we did some studies, I guess about a decade ago now, comparing the so-called sloppy hinge or Coonrad-Mori to the Hourglass, which was a Discovery, and to a concave cylinder, which was a Latitude. We compared these three designs, and what we found was that the new high-performance bearing designs are significantly superior to that of the Coonrad-Mori. So that is one of the impetuses for the redesign of the Coonrad-Mori to the Nexel, because the bearing in this implant was just not sufficient in higher demand patients. And the other problem with, of course, earlier versions of the Coonrad-Maury is smooth stems. And this is not something people talk about anymore, but I think it's really important if you're going to do elbow arthroplasty and you're thinking about this or you want to do research on it, understand that smooth stem implants in the elbow do not perform well. We know this from years ago. They put a PMMA plasma spray on the Coonrad-Maury stem, which had been performing well, but once they put this stem on, we saw a lot of problems with failure and loosening of the stems. We did a study in our lab where we compared the various types of stem options, a smooth stem, a beaded stem, and then a plasma spray stem, and we compared that with titanium and cobalt chrome stems. And what we showed was that both plasma spray and beads work well. Beads don't work as well on a cobalt chrome stem because they don't adhere to the substrate as well. So for a cobalt chrome stem, you probably should be using plasma spray, but beads work and plasma spray work well on a titanium stem. So this is why most of the implants you can buy now have some type of plasma spray or beads on them, because that prevents loosening of the stems. And this is a critical factor if you're going to choose to do a total elbow arthroplasty. Make sure your implant has some type of surface treatment on the stem to improve performance. I think one of the big concerns in the futures of total elbow arthroplasty is probably having uncemented stems. The problem with this is trying to find stems that a company is going to make is going to be very difficult unless they're patient-specific stems. And I think that's, if you were a young person here who wants to invent a new total elbow arthroplasty, it probably should be a patient-specific uncemented total elbow arthroplasty, because in this series from HSS, when they made these custom stems, they actually had no incidence of stem loosening or loss of fixation at 18 years of follow-up. Lots of issues with the bearings, but the stems were rock solid. And I think that's something we really need to be moving forward in the future of a total elbow arthroplasty. I think the other thing to consider is the effect of surgeon volumes. This is the other thing now we've learned, that basically if you want to have improved survivorship of your total elbows, you probably need to do more than 1 or 2 a year. And this shows the data of surgeon survivorship in the Scottish registry if you did less than 10 a year versus if you did more than 10 a year. And the 10 and 18-year follow-up is quite a bit different between the two. So I'm not saying you shouldn't do low volume elbow arthroplasty, but just understand, and certainly younger patients, maybe not fracture patients, that you may want to consider trying to group those arthroplasties in your group rather than have everyone doing 1 or 2 a year. The other problem with total elbow arthroplasty is it's hard to get the implants in correctly, and malpositioning of elbow arthroplasty is quite common. And this, of course, is why we have robotic knee replacements and other types of systems in reverse shoulder arthroplasty to put our implants in correctly. This is some data from our lab, which shows if you put in an implant incorrectly, the humeral component, no matter what position you put it in incorrectly, it's going to increase the forces on the stem and increase the risk of loosening. So again, you should not be putting these implants in incorrectly if you want to have long-term performance. So how do we fix this with a design? Well, in the Latitude system, we made you these mechanical guides, which we believe are somewhat helpful, but still it requires you to estimate where the axis of motion is for the implant. So they're really not perfect. It's not like a patient-specific guide. And if you actually try to estimate where the axis of motion of the elbow is, it's actually quite difficult. It's a complex geometric structure. We studied this in our lab, which showed that even 3 fellowship-trained surgeons had difficulty accurately positioning where the axis of the humeral component of a total elbow arthroplasty should go. So clearly there needs to be some improvement in trying to make our total elbow arthroplasties more durable. I personally believe that some type of image-guided surgery or patient-specific implants is what we need, where here you can take the uninjured elbow, if it's fractured, and transfer the axis over from a CT of the opposite side. We looked at comparing an elbow with intact bone versus bone loss, and we used standard techniques, with me being the surgeon, the so-called expert, and we compared manual implant positioning versus implant positioning using virtual models for guidance. And here, basically, the master's student, or sorry, PhD student, positioned the implants using image guidance. And this is the way we really need to go if we're going to use elbow arthroplasty at a high level with higher long-term performance. Well, how did we do? Well, not surprisingly, the surgeon had greater errors than the engineer, and you can see the difference in the setting of no bone loss. So even when there's no bone loss and it's as good as you can get, you can see my errors in positioning the humeral component, and it only got worse when we actually had bone loss. So in a distal humeral fracture, it's really quite hard to get the implant in the correct position. So I think the future of total elbow arthroplasty is to use either navigation or patient-specific guides, maybe the addition of robots or augmented reality. And this type of work is already happening in Japan. Eric and I were just there recently, and there's a lot of movement forward in using image guidance to place total elbow arthroplasties in Japan and showing really quite significant improvements. So in conclusion, when we think about where TEA designs are coming from, it's really a long, long history of failed devices. It's interesting how the implants look so different from one another, unlike, let's say, a knee. While our newer designs may have improved durability, I think we're not sure about that. And the future developments, I think, are some type of patient-specific uncemented implant using patient-specific guides, guidance systems, and/or robots. That's how we're going to take total elbow arthroplasty to the next level, like we're seeing now in, for example, unicompartmental knee replacement. Thank you. That's kind of the first talk. Do you want me to stop there, or Eric, or just fire ahead and then talk at the end?
Yeah, what if you fire ahead and then we'll kind of open up at the end for questions, if that's okay.
Sure, I think that might work best.
Yeah.
All right, so I'm going to share the second talk. Hopefully that'll come up.
Yep.
I'll just go to, okay, here we go. So this is what I was thinking about might be helpful for your trainees when you're thinking about how to get a more durable total elbow arthroplasty in 2024. There's going to be a bit of crossover with the prior talk, and of course I still have conflicts of interest. Just to remind you that total elbow arthroplasty hasn't been around that long. Here's the first total elbow arthroplasty performed in London. It actually was put in by a knee surgeon, obviously, so it didn't work out so well. But it did work for a while, and he's had about 4 elbow arthroplasties since then. It's kind of a long history of treating that particular patient. And we're hoping the new designs are better. So when I'm thinking about how do you get a good result, think about having the right patient, the right implant, the right surgical technique, and the right surgical team. And I think you should need to think a little bit about your rehabilitation program. So who's your best patient? If you're going to start a practice, for those fellows going into practice, who should your first total elbow arthroplasty be? In my mind, and it was my first total elbow arthroplasty on my first day of surgery when I came to London many years ago, is an acute distal humeral fracture in an elderly low demand patient. That's your best patient. Also, if, for example, if you managed a distal humeral fracture non-surgically and it fails, that's actually also a pretty easy total elbow compared to some other choices. And then finally, rheumatoid arthritis in patients with more generalized disease. These patients do really well with total elbow arthroplasty. They're technically a little easier than the worst choices, which are now below. These are patients, for example, you plated a distal humerus, or it was a terrible triad and it's all fallen apart. Those are really hard total elbows, and that's not where you want to do your first one. Obviously, heavy patients and male patients, they're more difficult than doing a slender female with rheumatoid arthritis. And finally, be careful in operating on patients who walk on their arms, patients with paraplegia, because I learned the hard way that you cannot touch the triceps in someone with paraplegia because they cannot protect their elbow post-operatively. They will, just to move in bed, they have to fire their triceps. So this is the kind of case you should think of early in your practice. This is an older lady. She has a comminuted distal humeral fracture. Yes, you could try to fix this, but why would you? the data shows that a total elbow arthroplasty is a good choice for this patient. And if you want to get better at elbow arthroplasty, this is the kind of patient you should put one in. So here she is 4 months later. You can see her clinical outcome. This lady continues to do well. She's never had a revision. And this is a highly successful procedure in an elderly woman with a comminuted distal humeral fracture. What's the data show? In our series that Jason Strelzow reported, 40 patients, almost all were women, almost all about 80 years old. It's interesting, when we saw them at 4 years later, only half of the patients were alive. So I guess we chose the right patients. So it's a very morbid condition. On the other hand, you don't have to worry about survivorship of your implant. We had no patient that had a revision for loosening, but we did have one infection, and that's the downside of doing a total elbow. Not that that can't happen in an ORIF case. And we had one periprosthetic fracture. So just like a reverse for fracture in an older patient, these patients keep falling. I was on call this weekend. One of George's patients had fell this weekend and has a periprosthetic fracture. So that's going to happen for sure if you do total elbows for fracture. But look at the Mayo score. Mayo score is excellent in this population. These are very happy people, and they get back to function very much quicker than if you do a complicated ORIF, and that's what the data shows. There's no question about that. And what about this patient, 58-year-old lady with rheumatoid arthritis? Here she is. She had an unlinked arthroplasty. Probably could have been linked. She probably would have done just as well. She remains very happy. This has been transformative for her life. She has no pain in her elbow and continues to function very well. This patient is more complicated. Yes, you can do a total elbow arthroplasty in this patient, and really there's not much other choice other than a fusion, I suppose. But really, or you can do a allograft reconstruction. We can talk about that in the question period, but this is a complex situation because now the olecranon is also deficient. So in addition to doing the total elbow, you have to do an ORIF and reconstruction of the proximal ulna. It can be done. It's a hard total elbow, but again, this has been a very good operation for this guy. He's now about 8 years out. And you can also use it for things you might not have thought of using. This is a lady that had a failed Montasia. Her plate's broken. The ulna's eroding into her humerus. Again, a good result in this older, low-demand patient with a total elbow arthroplasty with proximal ulnar reconstruction. Now, this is a great patient to do. Again, a patient that's older, a flail elbow. It's hard to make this lady worse other than if you cut her ulnar nerve, which is possible, because really, if the total elbow fails, you just take it out and she's back to square one. So again, this lady's got a stable elbow. She's a year later, and she's one of my most grateful patients. She always brings me a bottle of wine every time she sees me, which is not a bad thing for an elbow surgeon. It's not like the shoulder practice, my friends. And then the other question is, what implant? Well, we don't really know what's best. We talked a little bit about this in the last talk. You can make a choice. I think for most of us that are lower demand surgeons, we're going to choose a linked implant or a convertible implant today. Remember that newer designs aren't always better, and there's some concerns about the Nexel, at least in the Mayo experience, but some other data showing pretty good results with the Nexel. So we're not quite sure why it works sometimes and why it doesn't work other times. If we look at the finished joint registry, the bottom line is you can put in any elbow you want. Unfortunately, all of them have a higher failure rate than a total hip. So this is patients with rheumatoid. You can see at 10 years, they're about 85% survivorship. We'd like that to be better. What about unlinked designs versus linked designs? Well, these are all older implant designs, so we don't really know if they're actually truly inferior to the current linked designs. And again, more research needs to be done to help us decide that. What we found when we compared our linked and unlinked in the latitudes, the problem here is we were using two different designs, right? We had the earlier designs of the latitude, which had smooth stems, which tended to fail because they got loose, and now we've got the new EV. So we found a difference in the failure mode of the two. But what you see, interestingly, the unlinked arthroplasties fail early because of instability, but after that, they actually do very well. So again, we still don't know in a randomized trial, is there any advantage to doing an unlinked arthroplasty? Because that data looks like that, most people don't do unlinked arthroplasties. But again, if you were 35 years old and a JRA patient, you might choose to put in an unlinked arthroplasty, at least I would. Our data shows that when you link a total elbow, the forces in the humeral component go up 30%. So again, linking an implant does put more stress on the implant. And you can see here as we move to the linked implant shown in red, that the forces in the stem go up. So there's a downside to linking an unlinked implant. And we showed you this already. Bearing wear is the issue, causes osteolysis and failure. The older implants caused a lot of trouble. The newer implants, it looks like the bearings are performing better. And this is true not only for the latitude, but also for the discovery. And probably, we're hoping, at least for the next L. So choose the implant that you want to use, and I would say stick with it. Get good at one implant and don't jump around too much. Well, what about doing the case itself? I think it's helpful. This is George Athwal's room. You can see all the people in there. I don't have that kind of interest in elbow arthroplasty, unlike reverses. Typically, you should try to have 2 assistants if you can. I think it's really helpful, at least the way I do a latitude. You should try to not do it on the weekend. So do it in elective time. See if you can get your scrub nurse or a scrub tech to have some knowledge of the system. And you should also have your rep to come into the room to help support your staff. But you don't want a mob scene like you see in the Athwal OR, where there's just so many people. It's probably not good for infections. I already showed you this, that again, you want to get these implants concentrated, and the data shows that most centers should not have 5 surgeons doing elbow arthroplasty. It should be concentrated so people could get better. What are the things I think about? How do I optimize my surgical technique? Well, of course, we all use antibiotics. What's changed is I always use TXA, and that's been very helpful. We use efficient surgery, so we try not to make a total elbow arthroplasty last 4 hours. I use a lot of monopolar cautery now to try to diminish bleeding, and that's been a big change. I always deal with the nerve first and protect it. I manage the triceps usually by not detaching it. And then we use some type of instrumentation that you need to get used to. Again, get used to the system that you use. When you're putting in an elbow arthroplasty, make sure you do not use a large hammer or you'll break the bones. And again, we're going to talk a little bit about cement restrictors. So what about the surgical approach? The reason that a lot of surgeons don't like doing total elbow arthroplasty or even elbow surgery is that the triceps is always in the way, and so is the nerve. You can decide which way you're going to do it. I use the lateral paralecranon approach, and we published that over 10 years ago now. This is basically an incision that's an extended Boyd approach. You go down the lateral margin of the ulna, come down along the lateral edge, and you split the triceps centrally. This has worked very well in our practice. Our data shows that really the outcomes, clinical outcomes are better. And this is a series from South Africa, which showed the same thing. This is a paratricipital approach compared to a triceps off approach. But you can see the complication rates are higher if you detach the triceps. So you need to leave the triceps on. It makes it harder to see, which is why I do a paralecranon approach rather than a paratricipital approach, because I can see better. What about cement? Cement matters in a total elbow arthroplasty. Most of us use antibiotic-containing cement. I use this cement, which has it already preloaded. But if your cement doesn't come with antibiotics, I suggest you put some in. We use cement restrictors routinely. We vacuum mix, and we use a cement gun with retrograde fill. These are all things which I think if you look at a lot of total elbows that are done, they're not done with good cement technique. And this is our data from our lab many years ago. Ken and Faber, my partner, shows the difference between advanced cement technique in a cadaver bone versus conventional technique. And that actually matters because the strength or push-out force is doubled if you have good cement technique. So if you want a durable total elbow arthroplasty, do a good job with your cement. Get the axis of motion correct. So don't just put it in anywhere you can. Try to get the axis right. I already showed you this, that axis position matters. And again, trying to estimate the axis is a challenge because it has a complex geometric relationship. The second thing to remember is when you don't have a distal humerus, don't do what the literature says in some literature is you don't put the humeral component parallel to the flat spot. You actually have to internally rotate it 14 degrees. This is the number which is extremely important because 50% of the total elbow arthroplasties that are done today in America are for fracture, and you don't have good landmarks. So how do you landmark the component? The humeral component should be 14 degrees internally rotated relative to the posterior flat spot, and the flange and on bottom right should be at the top of the olecranon fossa. That gives you the approximate depth of insertion. So those are the two key factors when you're thinking about how to position the arthroplasty in the setting of trauma. Finally, rehab. Does this matter? I think it's actually pretty important. We found that putting the plaster slab on the anterior surface is better. We now use a fiberglass slab because these patients keep it on until the skin is healed. So that's a big change. I was always taught to move early. Here's a case in the bottom right. We moved too early, and you can see the skin is necrosed. And now you've got a disaster because they're going to need a radial forearm flap or something to cover that area. I think the rehab is different for linked and unlinked. Once we start them moving, we of course don't take an unlinked arthroplasty out to full extension right away, but we do for a linked. If the triceps intact, then you can really go very quickly with active range of motion. And if you're doing a linked arthroplasty with the triceps on, like a lateral paraolecranon, after you take the splint off, it's just go, go, go. There's no limitations for the patient, and they can return to life very quickly as soon as you take off the splint. If you detach the triceps, you have to be very careful not to have the therapist push flexion too early, because they always understand they don't want to activate the triceps for extension, but they're always trying to push the elbow into full extension right away. And I think that's why the triceps tears off if you detached it, if that's your preference. So in conclusion, when you're thinking about how to get the best total elbow arthroplasty, choose the right patient: elderly, low demand, fracture patient. Choose the right implant. I'm not suggesting a latitude is the best total elbow arthroplasty. I don't know that. What I'm saying is choose an implant that you're comfortable with, where the performance published in the literature is acceptable. Have a good surgical team. When you're starting this in your own practice, let's say for the fellows, maybe ask a senior surgical colleague to help you, or a senior kind of fellow to assist you when you're doing your first case. Be ready. Meticulous surgical technique. I always do these first case of the day when I'm nice and fresh, and so I can try to be super efficient. And finally, think about your rehab. Make sure you get your team on board so you don't wreck what would otherwise be a good surgery by moving things too soon. Thank you very much.
Awesome.
Take some questions.
Awesome. Thank you so much. That was incredible. So I want to open it up to everybody listening, and particularly our fellows that are on. So Joe, Tom, do you guys have any questions for Dr. King?
Yeah. Hey, Dr. King, I'm Joe. I'm one of the fellows. Thank you for those talks. Those were incredible. Dr. Wagner, please remember to upload those because I'm going to need to watch them a few more times. I have a question about a specific case you presented. The gentleman that you had done a total elbow or the open distal humerus fracture that you had 8-year follow-up on. I'm interested in hearing your thoughts on that scenario for open fracture. How much do you worry about infection? Do you take any specific steps to mitigate infection risk? Do you do it like acutely at the time of presentation, or do you give them a period of antibiotics after you close the skin? How do you approach that specific clinical situation?
Yeah, that was, that's an unusual case, and there's a bit more of a story because that was actually, I did that case staged. That actually came from our trauma center, which is just up the road, and it was sent to me, and as you can see with the picture I showed you, and so I never, if I'm going to do a total of arthroplasty in a young guy who's in his 60s at the time, I'm not going to slab a total elbow arthroplasty in that case unless I've debrided it myself. So I actually took him back to the OR, re-debrided him. Actually, I found some grass in his elbow, which wasn't something I wanted to see. And so we actually re-debrided him. We actually put a cement spacer in him. and we actually ended up staging him. And actually did him as a 3-stage. Again, no, I haven't published on that, but that kind of case, I would actually not even do him as a 2-stage. So we took him back, took the spacer out, recultured him, it was negative, and then we went ahead and did his reconstruction just because he was young. But I think the most common thing, Joe, you're talking about is, let's say it's an older lady with in their accommodated humeral fracture, and let's say in their late 70s, and it's a poke hole. If it's a poke hole, I treat that as I'll do a primary arthroplasty, and that's what the data literature shows. If you get to that early, then I would go ahead and she gets early antibiotics, early total elbow, and I treat it as a primary, like any other total elbow in the elderly, except I would do that urgently. I wouldn't wait to do that in my elective list. Unfortunately, I have to do it some other time. But again, if it's a larger open injury, I tend to do those staged, particularly in a younger patient, where you're worried about longevity of the implant, because the last thing you want is an infected total elbow arthroplasty in that population. And it will happen. So I think you should be very suspect, particularly if it's like sent from somewhere else, and they kind of maybe put an X fix on it. I think that's really the evil, where they put an X fix on it. Now you've got contaminated pin tracks. Do not fire a total elbow arthroplasty in that case. It has to be unstaged. Sorry, long answer.
No, that was great. I appreciate it. Thank you.
Awesome. Anybody else have questions from?
Dr. King, good to see you again. Fantastic talks. Obviously, as an elbow surgeon, I always love to see these types of things, even though there's very few, I feel like, nationally or internationally that do a lot of these. So it's always great to see a world expert talk about them. One of the questions I have for you is probably more of a broad question, which is, the innovations I think that we see coming down the line are probably maybe easy for you and I to say, hey, look, this is something that needs to be done. But getting companies to do them is hard because of the volume of these being done, that they never really want to spend the money on the R&D to push things forward, like navigation or robotic stuff. Because right now, especially in the US, total elbows are actually a money loser for the system. We just don't get reimbursed enough for doing them, and the implants are so expensive. Any thoughts of ways to combat this? I know Canada has its own issues as well as far as how to deal with things, but
yeah, I mean, it's a huge problem in our country as well, because the implants, like you say, are expensive. But our hospital, of course, has a contract for those implants. That's one of the way you can get your costs down, by bundling it with, for example, your shoulders or something, and you can maybe get them to give you a better price on them. That's one of the strategies if they're at all interested. But you're right, implant companies are not interested in total elbow arthroplasty. It wasn't my designing a total elbow arthroplasty wasn't my best financial move I've done in my career. And if you ask Sean and Ken Yamaguchi, we started that project over 20 years ago, and we could have made a lot more money seeing a few extra patients a month, and or doing a medical legal once a month, for what we made on that project. But that's not why we did it. And I would still do it again. We learned so much about how the elbow works doing that project, but it's frustrating, right? You might say, why is even the latitude, I would say, needs to be adjusted or tweaked, and we can't get the company to do anything about it. And to the extent that, it's very challenging to deal with them, because there's just no money in it, right? We designed an elbow arthroplasty right at the time that the volumes were dropping. So if you actually look, when we started that project, we're doing the same number of total elbows today as we were back in 25 years ago when we started that project, because the rheumatoids have disappeared. Now, it turns out the trauma is caught up and it's more or less an equal shot. But when the companies say they don't make any money on it, I don't believe that for a second, right? You sell a total elbow at the kind of prices they're selling, and they're selling them internationally, right? I'm not, but the bottom line is, Mike, they can make a lot more on reverses. Let's face it, right? They can make a lot more on a knee, particularly on a reverses when you control the market on reverses. So, the reverses are a growing indication. And I think eventually we will see some advances in elbow arthroplasty, but that's a whole nother discussion about innovation in general in orthopedic implant development. I mean, it's stifled in America. And it used to be good in Europe, and now they've stifled it as well by changing their rules for CE. The CE rules have changed, so now they're like the FDA, almost impossible to do anything. So I think the innovations in elbow arthroplasty are likely going to come from Asia and countries like China, who can actually do things with a little less regulation. Because a lot of these innovations, they're not hard to do, Mike. You know, with 3D printing, we could do everything we want in elbow arthroplasty in our own lab. All we have to do is basically get all the the processing and approvals of those implants sorted out. And I think that's the way elbow arthroplasty is going to go, because it's a small volume item. So the innovation is going to be probably reverse engineered stems with some type of standard bearing. That's probably as far as we're going to get in the next little while. I think if you had a patient specific guide to do a total elbow, that's probably all you need with a patient specific implant. That would actually be a game changer, I think, for the low volume surgeon, because when you're doing the 3 or 4 of these a year, it's pretty hard to make it perfect, right? You know, you even think you guys do what, a couple hundred reverses or maybe 400 reverses. I don't know how many you're doing at your place. We're doing about 300 now. You know, you can get pretty good at that even without patient specific guides, but it's hard to do that when you're only doing a few a year, right?
Yeah, I hate to monopolize the questions, but I'm going to say, as a senior person on here, I'm going to take my shot anyway and ignore my fellows and everyone else. My next question for you is, unfortunately, Eric and I see a fair number of disasters, as you can imagine, coming through the community. And whether they're loose or they have infection, we often have to revise them and put some sort of antibiotic spacer or equivalent therein. Have you had any success with an articulating antibiotic spacer in the elbow, or are you putting a static kind of fixed at 90-degree construct with cement up and down pins, or what's your go-to that you've done for over the years now that you've probably revised so many?
Yeah, well, yeah, I've got a long history of revision arthroplasty. I mean, the only good thing about the Latitude is, my revision practice has dropped, because when we were doing Kudran Moris around this area, we had a lot of revisions coming in, and we don't see as many, interestingly, as we used to. So I don't think other people are doing them. I just think revisions are dropping because people are indicating it arthroplasty is better. But we do see the infected cases for sure, Mike. And I've tried different things. And right now I've got a patient with a fixed stem rod. We actually made our long rod. We bent it to 90 degrees, and we made it a big cement L, and we put that in. And my plan is I'm bringing her back in a couple of weeks, and I'm just going to cut the pin and pull the 2 sides out. But you can only do that when there's a lot of bone loss. Otherwise, you've got to put each in individually. I've tried, the Mayo Clinic concept of putting a stem in and putting a linkage. That works in a very thin elderly patient, but the kinds of people I'm doing revisions on, they tend to break the pins at the pin junction. So I've stopped doing that, and I've gone back, to be honest with you, Mike, it's just putting a cement rod in with a blob and a cement rod in with a blob, and not making it a proper articulation. The other advantage of doing that is if you make the articulation too perfect, they don't come back because they're happy with their elbow. So again, if you don't want to see them again, then you can do kind of a bit of a yoke in the humerus and put nothing in the ulna, and then they can kind of move around, and sometimes they never come back for the next stage. But I think most people would be better off having their next stage revision. So I just put 2 rods in. I love putting 2 rods in, because when you come back to do the revision, it's all ready for you. Just open it up, pull the 2 rods out, throw a reamer down, and put your stem in. So I love, people say, well, why would you do a 3-stage revision? Because I don't want to spend 4 hours ripping out a stem, cleaning everything out, and then starting a complex APC reconstruction in a probably contaminated situation in a younger patient. So in younger patients, I tend to do 3-stage revisions in those terrible cases, just so I can make my life easier and prepare for the second stage to be a quicker operation rather than a 6 or 7 hour operation. I've been involved in 7-hour revision total elbows. Maybe Nina would just say I'm slow, but some of these reconstructions are so complicated. You're better off to just stage it for your coronary arteries, and probably for the patient.
No, thank you, sir. Really appreciate your honesty and all your experience.
Two questions, Graham. You just mentioned 3-stage. So your first stage is taking out, putting in the spacer. What's your second stage? You're on mute.
Yeah, these are cases, sorry, that would be a 2-stage. A 3-stage is an infected revision.
Right.
Okay, so infected revision, they get a big debridement,
Yeah.
put in the antibiotic spacers.
Yeah.
And then I come back. The second stage is to pull out the spacers, re-ream it, reculture it, and put nothing in. Put nothing in.
Oh, nothing in. Okay.
Okay. And that's particularly if they grow staph epi or something, something that's bad or gram negative. And then the third stage is I come back and put in their elbow. So it depends. It's kind of a 3-stage for an infected revision or a suspected infection, right? Where something's fallen apart. You have no bug, but it shouldn't have fallen apart. Those are the cases I treat like infection.
That makes sense. Have you do you link the 2 rods that you put in, or do you leave them unlinked? Like, or do you?
As I was saying, I used to link them with a,
Yeah.
I'd put in a, a DJD clip, but they tended to break. So I have not been doing that.
Usually,
Yeah.
yeah. My
Too
problem
much
was
moisturizer.
I've had a
Yeah.
couple break the ulna, like the rod broke through the ulna while I was linked with. Anyway, so I kind of went away from that as well.
Yeah, yeah. I think you're right there.
One question I had for you was their previous question, got your previous question about innovation in total elbow. One of the innovations I really wish we would have here in this country, I know you all have it in Canada, is a hemiarthroplasty for fracture, because I do feel like that would expand my own personal use of fracture or arthroplasty for fracture and distal humeruses. Can you maybe just talk briefly about your experience with that? I know we already talked a little bit in Japan about this, but about your experience with distal humerus for fracture. Sorry, arthroplasty for fracture in the humerus, and do you think it'll ever come to the States?
Well, there's two. First of all, I'll answer your question about hemi for fracture.
Yeah.
I mean, I think, we've been very careful not to do a lot of hemis for fractures in older low demand patients. So if it's an older low demand patient, I just do a linked arthroplasty total elbow. And that's really, been a very durable operation in our hands. So I don't want to take a 90-year-old and start experimenting, right? So that's something that I've done. Probably in retrospect, I was too careful. And so I tended to use it in coronal shear fractures in 60-year-olds, 70-year-olds, particularly men who, they're going to go golf no matter what I tell them. So I do a hemi in that population. So our hemi results have actually been pretty good. We're looking at them right now. If you look at the literature now coming from Europe, RCT coming from Sweden, no difference between a hemi and a total. And I believe those people. I've visited there. They're very honest reporters, and they actually have no vested interest in reporting anything about the latitude. Most of them aren't consultants, or if they are, it's kind of a side gig for them. It's not important, right? So the data shows very good results in Great Britain now. Hemis are outselling totals for fractures of the distal humerus. So they're actually more common, and it's actually pretty easy to put in this humeral component in a hemi. So I think the problem in doing a total elbow for fracture is you can't see the ulna. And even myself, I've taken a Kuhn-Mori stem and put it out the side of the ulna doing a total elbow on an 80-year-old, because you can't even feel their bone, it's so soft. Whereas a hemi, you take out the bits, putting the stem in, I can let an R1 do a hemi stem. So I have no concerns about them putting the hemi stem in. The problem is you still have to fix the epicondyles and get some type of stability. In some countries, some people aren't even fixing the epicondyles. They put this component in and just put the elbow in a splint and they'll let them move. And they're actually having pretty good results, because don't forget, the hemi that we have is not the hemi you have. So it's an anatomic shaped hemi. And so it's actually pretty constrained when it's reduced. It's just like a total elbow, a normal elbow. After you reduce an elbow dislocation, it doesn't try to fall out all that hard. It's not like a shoulder. So to answer your question, are the hemis coming to America? Well, the problem is the FDA has no predicate device. So the way it works, therefore you have to do an IDE, which will cost the companies, $20 million to do that. And think about it, if you were a company, So you're gonna sell one component or two. So you're gonna charge the same price for a Hemi as you do for a total? They can't do it. So they're actually gonna lose money by doing the study. I mean, that's not what they've told me. This is all, you know, my conjecture, but they've had no interest in getting the Hemi approved. Based on that, what I think we need to do is have a different company do a Hemi personally, where they don't have a total. They can easily make a Hemi. You know, I could draw you a Hemi on a napkin you can make for a fracture. And they also know that, you know, the big boys know that as soon as they get the Hemi approved, everyone else is going to make a Hemi and their market will disappear. So I hate to be a negativist, but it's all business. And, you know, I've been working with industry for 25, almost 30, well, 30 years now. And they definitely think about return on investment. You know, it's just like you put your money in your savings account, you expect it to get a return. And if it's not a return, you're not going to put it in the bank. So,
Yeah, that makes sense.
so sadly, they're not coming quick, I don't think. It's actually the most common reason Americans try to come and see me in Canada is for a Hemi.
Yeah, I can imagine. I can imagine.
Yeah.
Awesome. Any other questions? Awesome. Well, then, why don't we let you get to the game 7 of the Stanley Cup? Thank you so much for joining us. That was incredible, absolutely incredible, as it was, even better than the special day. So thank you very much for joining us. And look forward to, I'll see you in San Antonio if not sooner.
Yeah, not sooner. Okay. Maybe in ASSH, right, Nina?
Oh
That's
yeah,
right.
actually, no, I'm sorry. I'll see you in
Completely.
Minneapolis.
I guess I'm going to show up at the ASSH, right?
You better, you better.
I hear there's a free dinner with shoulder surgeons. How could I miss the shoulder surgeons? All
That's
right. You take care. Thanks
Yeah.
for inviting me. I'm really honored, by the way.
Thank you very much.
Bye now.
Bye-bye.